Okay, so we have no conflicts to disclose. Next slide. However, you may have noticed that we may be three people who are a bit conflicted with different perspective on the topic. As you know, Annie is the mother of a wonderful girl, Violette, who was born at 24 weeks. Rebecca will be sharing her story. And for me as a pediatrician, I already told you that if I see a child with cerebral palsy, for me, it doesn't really seem impaired, but can have a totally perfectly normal life. So we may be coming with bias into this topic. Next slide. So today's plan, I will first be discussing why neonatal outcomes are being measured. Rebecca will then be sharing her story, and then Annie and myself will be presenting the Parents' Voice project that we've been conducting over the past 4 to 5 years. So as you may all know, worldwide, 10% of babies are born preterm before 37 weeks of gestational age, and about 1% are born extremely preterm before 28 weeks of gestational age. And nowadays, survival rates are pretty high. So these are the numbers from the Canadian Neonatal Network. So at 27 to 28 weeks, close to 95% survive. At 25 to 26 weeks, we have an 86% survival rate. And for infants born at 23 to 24 weeks, it's 62% of survival. So really now, the issue is not that much survival as it used to be. I mean, it still is for certain babies, but for majority, now the goal in the perinatal care is really to have a healthy survival. So as a pediatrician, this is why this is where I'm standing. So neonatal follow-up is really important so we can monitor how preterm infants grow and develop. And these are some of the lovely kids I see in clinic. So what do we do in follow-up programs? We usually have two hats. So the first hat is the clinical mandate, and the second one is the academic/research mandate. So on the clinical standpoint, as a pediatrician working in a neonatal follow-up clinic, I will see preterm patients to monitor their growth, their neurodevelopmental progress, and their health with a specific focus on problems known to be associated with preterm birth. So this way, early recognition of problems will lead to action to prevent long-term morbidity and improve health. So for example, if I observe early signs of motor delay, I will refer this patient to physical therapy for early intervention so I can really improve long-term functional outcome. Follow-up is also important to accompany parents in their journey to inform them about what to expect and help them make decisions after discharge from the NICU. On an academic standpoint, as a researcher, I will be collecting outcome data. This is important for audits to monitor practices in the NICU, and it allows for improvement of the quality of the care which we are providing during the perinatal period. Also, when I'm collecting data at my hospital, I bring this information back to my colleagues in obstetric and neonatology so they are aware of how preterm children and their family they care for at our hospital evolve. So this allows them to provide more personalized information to parents in the NICU. Standardized data collection is also useful for observational cohorts and in clinical trials, examining new intervention to prevent neonatal complications. Long-term follow-up can ensure that there is no unexpected adverse events. Next slide. So what are we collecting exactly? So this is what the Canadian Neonatal Follow-up Network is currently collecting. It resembles what most international cohorts or networks are doing. So we have a standardized follow-up visit at 18 to 36 months corrected age, where we perform a neurological examination to identify signs of cerebral palsy. And then if a child has cerebral palsy, we'll be using the gross motor function classification system to determine severity level. We also perform developmental assessment, most often using the Bayley scales of infant and toddler development, so we can get a language, a cognitive, and a motor score. We also look for hearing function through audiology report and visual function through ophthalmology or optometry report. And then we take all this information and put the child in a box according to neurodevelopmental impairment. So we usually look at 4 domains, cerebral palsy, developmental delay, hearing impairment, and visual impairment. And if the child has none of that, there is no NDI. Then, for mild to moderate neurodevelopmental impairment, how it is usually defined in many networks, it's cerebral palsy with a gross motor function classification system of 1 or 2. So usually those are children who may have stiff legs, but don't usually require any aids to move around. Developmental delay is going to be any children with a Bailey score 1 standard deviation below the mean, so that would be between 70 to 85. Any hearing impairment or any visual impairment, but that usually don't require any special aids. And then for the severe NDI, it's usually children with a gross motor function classification system of 3, 4, or 5, meaning that they need some help to move around. But some networks have a more strict definition, only using children who really require a wheelchair for for even like short distances. Developmental delay will be one child with a 2 standard deviation below the mean, but some network will actually use 3 standard deviation the mean, having a more strict definition. Hearing impairment is usually defined as requiring hearing aids, and visual impairment is going to be defined as bilateral blindness. So, as I mentioned earlier, this child, for example, who has cerebral palsy and require an aid to move around would be classified as a child with cerebral palsy and a gross motor function classification system of 3. So according to several networks, including the Canadian one, the NICHD follow-up network, the Swiss network, this would be classified as severe neurodevelopmental impairment. But you can also see at the same time that putting this, just looking at this children based on his development might be like a limited view, because for me, when I look at him, he looks pretty happy. And this is how actually like this whole project started. And I will now let Rebecca continue.
Thanks, Mai. So on Monday, September 21st, 2009, my children, Maren Irene and Lily Ruth, were born at 25 weeks and 5 days gestational age, weighing 760 grams and 840 grams respectively. They were born after a weekend spent at Sainte-Justine Hospital in Montreal, where doctors had tried to stop my labor that had unexpectedly started 3 days prior. My husband, Jason, and I had no idea what it meant to give birth to babies who were so premature, and the next months were the most traumatic and difficult of all of our lives. The following Sunday, a week after their birth, Lily developed an infection that led to intestinal damage and a brain hemorrhage, and she died that afternoon. It turned out that Maren had the same bacterial infection, and she was started on a course of antibiotics. Several weeks after birth, she required a PDA ligation that was risky because of her instability. She caught a fungal infection that needed treatment. She developed severe BPD and spent lots of time on 100% oxygen or on a high-frequency ventilator, and she had a number of respiratory crises. She was on a ventilator for a total of 7 weeks and required steroids to wean her from it. Finally, about 2 months into her NICU stay, things started to stabilize. And it was at this time, at the end of November 2009, that my mother died of cancer. And I'm not mentioning this for sympathy, but just to remind all of the neonatal practitioners out there that on top of the deep worry that parents have about their preterm children, they are often also dealing with other stressors outside of the hospital. Maren kept slowly growing and progressing, and after about 3 months, she was finally moved to the intermediate facility where we could prepare to take her home. Next slide. So during this time in the NICU, I obsessively read about all the bad things that can happen to extremely preterm children, but all the statistics in the world don't tell us much about individual outcomes for these children, and statistics don't mean much anymore when one of your children dies, despite the fact that most babies born at 25 weeks actually survive. Next slide. A few weeks before we thought Maren might finally be discharged, we were approached by a doctor about performing a head MRI in her. At the time, this was standard for babies born below 26 weeks gestational age at Sainte-Justine, and we agreed without even really thinking about it. Shockingly, the MRI results indicated that there was moderate damage to Maren's cerebellum, caused by a previously undetected brain bleed. This news was completely unexpected, and nobody could tell us what this devastating diagnosis meant. So with this knowledge, Maren was discharged from the hospital at the end of January 2010, 4 months and 1 week after her birth. Now remember, most people like me have no idea about the impacts of preterm birth on the long-term outcomes and the development of children. I did know my way around Google Scholar and PubMed, so I turned to the medical research literature to try to get an idea of what Marin's medical history might mean for her and for us. Now remember, Marin was born at under 26 weeks gestational age. She weighed 760 grams, had PDA surgery, a number of infections, was on a ventilator for 7 weeks and needed steroids, went home on oxygen, couldn't be held for weeks after her birth, and had cerebellar damage. What do you think that the research told me about the long-term outcomes of a child like this? Next slide, please. So as Mai just discussed, there's a substantial focus in preterm birth outcome research with neurocognitive outcomes, for example, blindness, deafness, cerebral palsy, and IQ of less than 85, but also things like learning disabilities and vision problems. The trouble with these measures is that they are always reported as dichotomous. So either the child has it or they don't, without acknowledging that most of these outcomes are continuous and fall within a range. For example, children can have a variety of vision problems or have a huge diversity of learning differences or disabilities. There's also very little research that examines what these neurocognitive outcomes mean for the quality of life and for the day-to-day functioning of preterm children and their families. Marin had visits to the follow-up clinic at Sainte-Justine where she was given tests such as the Bailey. And while these tests can identify children that may need more follow-up care, they actually have limited predictive value, so they may not be relevant or helpful for parents. In fact, most of the outcome measures that have been chosen for research have been done so by you out there. So neonatologists, developmental psychologists, or clinicians, without considering what parents or families may consider important or impactful. So for example, Marin had to be rehospitalized with pneumonia numerous times before her 3rd birthday, which was enormously difficult for all of us. There is little, if any, research that considers rehospitalization as an impactful outcome. I really wanted to know how families cope with the stresses, with the uncertainty and the potential difficulties of having a preterm child, but information about this was hard to find as well. What was very easy to find was very medicalized, deficit-based research that focused on all the problems that preterm children as a group have without any sort of discussion or examination of their positive attributes and what they can do and be. I was recently reading a study that asked about parents' perceptions of the health-related quality of life of their children with severe BPD. The author noted that the normal emotional health of preterm children may be an area of resilience that is under-recognized. And I sort of laughed to myself and thought, well, it's under-recognized because nobody seems to really value resilience as an important outcome to study. This may sound harsh, but I find it very strange that as a society, we spend huge amounts of time, money, and effort to medically intervene to save extremely preterm children, only to turn around and spend more time, money, and brain power to conduct research that suggests how atypical they are and how in many measures they are inferior. There's a large body of research indicating that preterm children as a group have lower cognitive scores and more academic difficulties in school, particularly in mathematics, than their matched peers. Why have these outcomes been prioritized for such extensive research? And again, who decided that IQ and standardized test scores should be used to define success or outcome? As you will see from some of the data that will be presented later in this talk, parents are pretty realistic about their concerns for their children, which do include developmental delays and difficulties in school. However, for many parents, this is just part of who their child is, and it doesn't necessarily have a massive negative impact on day-to-day happiness or quality of life. The voices of parents and preterm children are largely absent in outcome research, though this is slowly starting to change. These voices are so important because they provide a critical counterpoint to deficit-based research. For example, studies examining the quality of life and functioning of extremely preterm children as they get older have shown that these individuals generally rate their happiness and their quality of life is equal to that of their term-born peers. The majority of extremely preterm children end up as adults who are content, employed, living independently, and are contributing members of society. But this pretty important information becomes overshadowed by research that just focuses on what's wrong with preterm kids. One of the reasons that this parent-centered research is of great importance and interest to me is because I was curious to learn about other parents' responses to their children's preterm birth and how they regarded the impact of prematurity on their lives. This is information that is missing from the research literature that could be of great benefit to everyone. Next slide. So today, Marin is a happy, healthy 12-year-old. She just had her 12th birthday at the end of September. She started high school this year. So in Quebec, secondary school actually starts in grade 7. And despite being one of the youngest children in her class and being born 4 months preterm with all of the medical issues she had, things are going pretty well. She takes the metro or subway for Americans to school by herself each morning. She's bilingual. She loves to read and ride her bike and play with her younger sister. She plays the piano and guitar and swims in figure skates and does karate. She also has a slower processing speed and weak working memory, and she was recently diagnosed with a math learning disability. These are all hallmarks of extreme prematurity that we can read about in the literature, but they really matter less in day-to-day life than one might think. Marin is also kind, exceptionally hardworking, happy, resilient, and is liked by her peers, which are all traits that many other preterm children may possess, but that have been neglected in outcome research. Next slide. So, are we asking the right questions in outcome research? What's the purpose to some of the research that's being done? How is it actually contributing to improving the lives of preterm individuals and their families? Remember, some outcome research is picked up and reported by the popular media, and this unfortunately shapes people's perception of preterm individuals as somehow damaged. Outcome research is really important for a number of reasons, but it needs to be balanced. So we all know that extreme prematurity is devastating. There's absolutely nothing good about being born 4 months early. However, most preterm children are regular kids, and their prematurity doesn't necessarily negatively impact them or their families on a daily basis. Most preterm children do okay in school and have friends. Most preterm children are happy and don't have serious long-term health problems. Most preterm children are independent and functional members of society, and they're strong and resilient. And the parents of preterm children love and value them no matter what their neurocognitive status. Next slide. So I'm only one person, and I think I've clearly explained my perspective to everyone, but the bigger question to ask is, how can we integrate parental perspectives into the larger research picture? So this includes rigorously investigating what matters to families and what parents consider to be important outcomes, with the aim of improving what is meaningful to parents and families. And we can use different research methodologies in order to do this. Next slide. So in 2018, Magdalena Jaworski and her co-authors in Montreal published a paper entitled Parental Perspectives Regarding Outcomes of Very Preterm Infants Towards a Balanced Approach. In this study, 190 parents of infants born at less than 29 weeks were asked 2 open-ended questions at their child's 18 to 22-month neonatal follow-up visit. What concerns you most about your child? And please describe the best thing about your child. Data were analyzed thematically, and there were many positive themes that emerged from the answers to these 2 questions, themes that are not measured in outcome research. These themes related to child personality, happiness, health, and developmental outcomes that exceeded expectations. And all 190 parents had positive comments. Next slide. There were also parental concerns or negative themes that were found, including developmental concerns, physical health concerns, and concerns about their child's future, many of which are also not measured in outcome research. And interestingly, there were some parents that had no explicit concerns about their very preterm children at all. Next slide. So as Annie has said to me, Magdalena's paper was a kick in the butt, and that led to the idea of asking more parents similar questions in a more rigorous fashion. In 2018, there was also a great editorial published called What Parents Want to Know After Preterm Birth that included some very relevant questions and conclusions. Most notably, why have researchers chosen neurodevelopmental impairment as a measure of NICU success? Why has it become central to the way that doctors counsel patients and discuss prognoses? Do doctors actually answer the questions and the real concerns and the needs of parents of infants born preterm? And finally, the authors also note that it's imperative to redefine the ways that outcomes are described after preterm birth. Thanks for listening, and I will now turn things over to Mai, who will discuss the Parents' Voice Project.
So following, thanks, Rebecca. It's always hard to be following you. Easier to start before you, harder to come back. So after this paper that we published, we decided to launch the Parents' Voice Project, which is really like a pan-Canadian project. And these are some of the members of the team. We have the Montreal team with Magdalena, Annie, myself, and Claude-Julie Bourque, who's I was going to say a socialist, but I don't think that's how we say it in English.
Sociologist.
Oh yeah, sociologist.
Maybe a socialist too.
She's maybe a socialist too, but she's bring her sociology view. Rebecca and Kate Robson's our parents representative. Anne Sinnes used to be the former director of the Canadian Neonatal Follow-up Network, Paige Church in Toronto, and our wonderful CN Fund coordinator, Lindsay Richter. Next slide. So actually, like, the goal of the Parents' Voice project was really to engage parents to co-create definitions of neurodevelopmental impairment, but also to think about what are important outcomes that we should be measuring as part of our standardized assessment at follow-up. Next slide. So we had 4 projects, and this is the first one, which aimed to compare neurodevelopmental impairment classification as per parental view versus our medical definition that we were currently using and are still currently using in the Canadian Neonatal Follow-Up Network. Next slide. So what we did is, for 1 consecutive year, all parents of very preterm infants who were seen at the 21-month corrected age visit for follow-up were eligible to participate. And prior to their health and neurodevelopmental assessment, we asked parents the following question. Please tell us how you would rate your child's development. And they had 4 choices. My child is developing normally. My child has a mild developmental impairment, my child has a moderate developmental impairment, and my child has a severe developmental impairment. And that came with an introduction about why we were measuring outcome at the 18 to 21 month corrected age visit, also saying that there were really like no good or bad answers. We really wanted to seek their opinion. And so what we did was to compare the parental classification to the CN-FUN classification. Next slide. So these are the characteristics of the patients the participants who were recruited during a 1-year period. So we had 1,000 participants, but when we compare them to the non-participants, for most child characteristics, including gestational age, birth weight, presence of any impairment, they were pretty similar. And if we look at caregiver post secondary education, we had the same proportion of participants. It was very representative of the entire group. Next slide. So first of all, what was the agreement? The agreement was fair if we look at the scale with a kappa of 0.29. Next slide. And so here what you have is the classification as per CN-FUN that you will see on the vertical columns. And on the horizontal row, you will see the parental classification of neurodevelopmental impairment. So if we look as per CN-FUN classification, 54% of children were considered to have no neurodevelopmental impairment. And if we look at the parental perspective, 68% were considered to have no neurodevelopmental impairment. Now, when CN-FUN classification said that the child did not have a neurodevelopmental impairment, 83% of parents agreed. When we came to the mild to moderate NDI category, only 40% of parents agreed. And if we look at significant NDI, as you can see here, only 12% of parents agreed. So you can see that physicians tended to classify children's level of impairment more severely than parents. Next slide. So in summary, the results showed that there was only fair agreement between the parents' perspective and healthcare provider regarding the outcomes of the preterm child. And as I mentioned, parents were more likely to describe their child development as normal or less impaired. And now I will let Annie continue.
So there were 4 aims in the parent projects, the Parent Voice project. And the second aim was to explore the parental perspectives and remember the Jaworski's paper, the main concerns and main positive points. So we took the themes that the parent had spoken about and made a quantitative questionnaire out of it. And we aimed to have different groups answer that questionnaire. So the questionnaire is divided in 4 sections, mainly based on what parents had said. And we used a 5-point Likert scale. So it asked about personality and social interactions, positive aspects about the development, and in the concerned, what they were concerned about. So the questionnaire was actually done in 2 Canadian institutions, Vancouver and Montreal, where not the same languages are spoken and where cultures are slightly different. And 199 parents participated. participants and non-participants were comparable. So when we look at the results for the questions of how well the child was developing and the child's physical health, you can see here that in blue, it's parents who agree. In gray, it's parents who neither agree or disagree. And in orange and yellow, it's parents who strongly disagree. So the parents' appreciation of their child's overall development and physical health was very good. It's always above here at 78%, 96, 84, and 96%, depending if the child had an NDI or no NDI. Appreciation, of course, as we can see here, was higher among parents of children with no NDI, but still parents of children with NDI had a high appreciation. With questions about personality and if the child is happy, laughs and smiles a lot or has positive social interactions, parental assessment of their child's positive attribute were very good, independent of NDI. There was very good positive outlook and happiness and personality. And you can see here, you see very few lines of yellow or orange. And the only place where NDI actually just influenced a little bit with 1 to 4% of parents who disagreed is with social interactions, 4% of parents. But there were many concerns. You can see concerns here, depending on NDI, parents of children who didn't have any neurodevelopmental impairment in green and orange, parents who had children with neurodevelopmental impairment. And you can see the percentage of parents who were concerned. So even in parents of children who have no neurodevelopmental impairment, a parent have concerns about their development, their future, and their physical health. So there's some impairments that are higher in parents of children who have NDI, especially in physical health. And you have to realize this was never actually asked of in parents who have children born term healthy, because many parents still have concerns with their healthy term children. What was also surprising is what we actually forget to investigate after follow-up. So for example, and what is really concerning to parents, you can see that 2/3 of parents are concerned with eating, a lot with breathing, of child often being sick, frequent visits to the hospital, sleep, and frequent hospital overnight stays. These are concerns that are not investigated. So for the AIM-2, the summary of results are that parents of children born very preterm have a balanced perspective about their child's health and development. They recognize their child's happiness and positive personality independently of their child NDI status, but they also express concerns, mostly about development and physical health. And those numbers are not used during prenatal consultations, and perhaps they should be, to tell parents that all the parents at follow-up find their preterm happy with a positive personality would be something that would be actually valuable. So the third aim and the third project was to use vignettes to evaluate parental perception of severe disability. There were some clinicians who participated in there, and as well as some children and adults who were disabled. And this is one of the ways when comparing vignettes that we are able to put a ranking on disability. For example, why do we think that blindness and deafness are equivalent? Perhaps when you ask anybody in the street, they will tell you, oh, you know, I'd rather be deaf than blind, but yet we give them the same weight when we say severe disability. And perhaps there's some mix of disabilities that are worse than one single disability. So we created several vignettes developed on outcome definitions, severe, moderate, mild. We prepared a survey on REDCap, and they were distributed to British Columbia parents or very preterm children, and we made them available on the web in parent foundations. So this is an example of the vignette 1. Jamie is an 18-month-old child. He can sit with support, roll and creep on his stomach. He has stiff legs and will very likely use a wheelchair for longer distances at school. He can see and hear normally. He learns like other children his age and likes to play with other children. He can follow simple directions and use words like other children his age. So we asked between 0 and 10, how severe and how do you fit Jamie on this scale? And does Jamie's case describe a severe health condition? So Jamie here has only cerebral palsy or severe neurodevelopmental impairment with cerebral palsy. So if you look at the several vignette, 827 participants answered and compared vignettes. A child with no impairment, as you can see here, had a median estimate of 10 on 10 in terms of health. And as you go down, you can see here children who had, for example, what I wrote, red, Jamie had a 7 on 10 evaluation. And if you ask about cerebral palsy and language impairment, this was judged to be the worst outcome in all of the vignettes that we chose. But you can see that hearing impairment had a ranking of 8 on 10 and was ranked much better than visual impairment at 6. And this is the percentage of respondents that rated the vignette as a severe healthcare condition. Even cerebral palsy and language delay, about half of respondents thought this was a severe health condition. And when you look at only cerebral palsy, we're at 43%. And you can see that people didn't rank one with 100% of people. So in summary, clinical vignettes are ranked differently. They're not ranked the way disabilities are classified in neonatology. The percentage of respondents who perceive the clinical vignette to be severe differs significantly. And generally, it's less severe than how it is described in neonatology. Many delays that are described as severe are not perceived as severe by parents and stakeholders. And we can see here that when you combine cerebral palsy and language delay, this was perceived to be the most severe vignette. So the last aim was had a lot more open-ended question and was only done in Sainte-Justine. And we really asked open-ended questions, many of them to parents, to explore their perspectives in terms to the health of their baby, the impact of prematurity on their child's life, but also their family and their parents' lives, their need for information about prematurity, and what they regretted. So during the whole year, the group asked parents of children seen at our follow-up clinic who were born at less than 29 weeks of gestational age a number of questions. And all the parents were approached either if they were seen at the 18-month follow-up, 3 years, or 7 years. Here we have a very high number of participants because we actually asked parents how they wanted to answer. They could answer online, they could answer on the phone, they could answer on paper, with an interview, with an iPad at the clinic. There were 6 ways to participate. And we told them, we need your voice because we need to know what's important to you, and we would like to have it if you want to participate. And parents enjoyed participating. Then we analyzed what they spoke about and did a thematic analysis with a multidisciplinary research team. And this would be interesting to speak more about this, but every time we defined a theme, we actually defined it with 12 people around the table, including medical students who didn't have parents, a parent, a sociologist, a neonatologist, a developmental pediatrician, a rehab pediatrician, and we had to agree. And then when the parents' stories and narratives were coded, they were coded by two different people, and there was always a parent who coded interviews. So we were very happy because, as you can see here, you have the emoticon of happiness, but you can also see that 83% of eligible kids for follow-up showed up, and 98% of parents who came to follow-up participated over 1 year. The children, the participants, those who came to follow-up are similar, but those who don't come to follow-up, in fact, tend to be less disabled. The characteristics of the 213 children, they were born about 26 weeks on average, with a mean gestational age of 900 grams. You can see in how we classify doctors' neurodevelopmental impairment, about half, like in other cohorts, didn't have any impairment, 25% mild to moderate, and 25% were classified as having a severe or significant impairment. So the first question was, please rate your child's health from your point of view on this scale, from 0, very poor, to 10, excellent. And the median ranking was 9. And for parents, we could see differences. For parents who have kids with no NDI, they generally said 9 to 10. Mild to moderate, the median was more of 8, and significant NDI, the median was a bit over 7. We then asked them an open-ended question. If you could improve up to any 2 things about your child's health and or development, what would they be? And this lets the liberty of parents to say what's important to them, what bugs them the most, and anything they could improve. You can see the circle here in blue, 19% said nothing. 25% spoke about respiratory health, respiratory fragility, coming back often to clinics, coughing, rehospitalizations. 15% spoke about nutrition and feeding and growth, and 55% spoke about development, mostly language and communication, then very important behavior and emotional health, and less important motor development and cognitive and learning skills. We then asked parents, this was a quantitative question, to choose the statement that best fit their situation. So my child prematurity only had positive impacts on my life. So 19% of parents answered it only had positive impact. My child's prematurity had both positive and negative impacts on my life or my family's life. This was the majority of parents. Or my child's prematurity had or has or had only negative impacts on my life. And 7% of parents answered that. So you can see the majority of parents were described positive and negative impacts. And then we asked them, again, an open-ended question, please tell us 1 or 2 positive impacts of your child's birth that you consider the most important. And parents, these were the 3 main themes invoked by parents. Their outlook on life and the gratitude, how their life had changed, how their life was better because they had a better outlook on life, focused on what was important, put things in perspective, were better people. The second theme had to do with stronger family connections. A lot of couples felt stronger together, closer to their family. And also, of course, the child. That was a gift. In percentages, you have how many parents invoked that themes. And I'll give you an example of the stories of parents. So here a parent said, my baby has brought together our family and friends. I see life differently, the importance of the present moment and letting go. My daughter's birth has helped me learn to focus on the present situation, along with learning that nothing is impossible. Seeing her walk, talk, and doing something as simple as breathing is just so amazing. Or my child is a miracle in our lives, and his strength and resilience gives me strength and resilience. In the negative impacts, there was a lot of themes invoked. Which were the worst? Parental stress and anxiety. A lot of the quotes that we read, even after 7 years, you could tell some parents still had post-traumatic stress disorder, for example, and most of them didn't really describe if they were follow-up for that. The loss of family balance and equilibrium, for example, during rehospitalization or during the many appointments, the child development and worrying about it, or the vulnerable child at school fearing infections and things like this. And I'll give you examples of what parents said. This is related to anxiety, not necessarily only for that child, but for example, for another pregnancy or for another healthy child that you know now all the terrible things that can happen very quickly. So constant fear during my second pregnancy. My career dreams extinguished. Such quotes were more frequent at the 18-month follow-up, where the first 18 months is really more demanding. Although he is doing amazingly well, there's still a lot of anxiety for what the future will hold. Feeling that I experience motherhood abnormally, loneliness, the fear of losing our babies, the hypervigilance that has persisted since we left the hospital. This was not a mother at 18 months who said that. She was at 5 or 7 year follow-up during that bracket, and she still checked if her children were alive during the night. The other question we asked is to know how can we improve our system? Knowing what you know now, what do you wish doctors would have told you about prematurity before and or after your child's birth? Half said they were satisfied with whatever they received as information and didn't think of anything else that they would add. But where parents mostly wanted more information, it's about the return home. When they were discharged, what to expect in terms of follow-up, in terms of appointment, in terms of rehospitalization, and practical considerations such as what in the daily life, in the baby care, how to avoid infections, and for example, telling parents of a child who's on oxygen that he should probably not go to daycare. And some parents learned that the day of discharge. There's 16% of parents that spoke and invoked the theme of more practical information on the NICU stay. So to learn the parental role earlier, what can I do as a parent? To learn about the trajectory of a baby, you know, CPAP to oxygen and then tube feeds, to learning how to feed. Ways to prevent complications of prematurity, such as speaking to your child or kangaroo care. And 14% wanted a better style of communication, more optimism, and parent medical team interactions to engage parents and empower them. So these are some of the examples of what parents said. After the birth, have ideas of what we can expect, even if each journey is different. I would have liked to have been better equipped for going out with all the bacteria, how to manage all this, what to do and not to do, how to protect him the most without having to be hospitalized every 2 weeks. In any case, give parents the most tools so that it does not happen. You can see that this mom answered via the internet. So she put, we actually took exactly the quotes of parents and placed them there. And sometimes they actually said the information, so we transcribed them. But here you can see there's a lot of exclamation marks. One parent said, speak to us about positive stories too, not only the negative and all the bad that can happen, it's impossible to always live in fear. Another parent spoke about the importance of function as opposed to diagnosis. Do not just speak about cerebral palsy, but about what we will have to do in a practical sense as a family. How many appointments, where, for what does it mean for others, the good and the bad? A diagnosis doesn't help much. What we can do about it helps. And the last question we asked families was about decisional regret. And it's very hard to say, what do you regret? Without parents feeling guilty. So the way usually in the regret literature that question is used is, knowing what you know now, is there anything you would have done differently? Half of the parents said, I wouldn't have done anything differently, or, you know, I told what I was told to do and I don't think I would have done anything different. I did what I could and I wouldn't have done anything different. But still, in the top themes that we found there were changes in the NICU, mainly about self-care and communication. Parents said they were exhausted. They didn't take care of themselves. When they were communicated with, it was hard to find their role as a parent. It took them a month to know what a parent does. And if they did something differently, they would know how to be a parent earlier and how to take care of themselves. Very hard to read the comments of one parent out of 6 that spoke about guilt, about preterm birth. Some moms still with a child who's 7 think it's their fault. They think it's all their fault if their child has a disability or not, went through the NICU, and if they could have done something, they would have done it better. And we don't really do a good job of actually addressing that guilt in the NICU. And 9% had regrets concerning parental role in the NICU. Had I known, I would have done this earlier. If I had known that, I would have communicated better with the team. I wish I had known the rounds were at what and what hour, and I would have participated more in decisions. Interestingly, there were no parents' reports regretting life and death decision for their child. This is what we hear very often when we're told we shouldn't intervene for these children. I see so many parents who say, when they come back, I regret, and if I had to decide, I would decide otherwise. No parent spoke about this. So these are examples of what parents have said. Listen to the nurses and go sleep, because we were there 18 hours a day in the NICU near them. I would have liked to know what parents can do earlier to get involved. I would have consulted the psychologists of the care unit immediately instead of consulting 5 years after birth. And one about the guilt of prematurity. I would have pushed for better care and monitoring during pregnancy, and when I thought something was going wrong, I felt as though I wasn't listened to and I thought I was in labor, when sure enough, I was. And these are quotes I now use in the NICU. And when I tell parents, we've asked all the families here during a year, and they tell us what they regret the most is not taking care of themselves. Because just saying go home, they think they're bad parents, or they think we don't want them there, or that they're a nuisance in the NICU. So these are examples of themes that can be useful to speak to families. So I'll finish with this slide of, we have to remain humble and curious and do research about outcomes with families, not just about families, because we're the experts of preemies healthcare, but parents and families are the experts of their children. And measuring patient or family important outcome is a complex matter. And I see a lot of mistakes of those who do this and who try to look at what are important or core outcomes, as we can see more and more in the literature. And the first mistake is validating medical important outcomes with stakeholders. So have a whole menu of the disaster, you know, all the 3-letter words, BPD, PDA, RDS, ROP, and ask parents, are these important to you? But these are what we decided was important to us. So we're mainly validating our list. The other mistake is to seek a consensus. As you can see, not all parents had regrets. About half didn't. Many parents don't have concerns. Many parents have very strong concerns. So to have a consensus of what is important is not something we should do. We should actually describe that variability. Another mistake is to do a research about parents, but not with parents, and not implicate them anywhere in developing the study. And what are the solutions? The investigations need to be representative. So an N of 6 is interesting to develop themes, but you can't, after asking 6 fathers, publish a paper saying this is what is important to fathers. So we need to give all parents a voice. So have methodological flexibility, whether parents want to answer via paper, internet, on the phone, and some may have literacy concerns. To use mixed methods and ask 300 parents or 200 parents. Ask different methods and look at it a different way, like asking all parents in Canada how to categorize their children, using vignettes, using a questionnaire, using open-ended questions. And you can see that parents speak about similar things in all these ways to ask them what they think. I would avoid only, I think qualitative methods are useful, but only quantitative methods with small n's, and then trying to generalize that. Usually in focus group, you'll have parents who are vocal, who feel comfortable to be around the table, usually moms, usually older educated moms. You don't have the voice of those who don't come to the NICU. Delphi consensus should also be avoided because many parents won't have a consensus on what's important. And purely quantitative questionnaires designed with non-parent experts should also be avoided. So the key messages is that parents have a generally positive perception of their child, that developmental issues are a main concern, behavior is important. Some parental concerns are forgotten in our outcome measures, such as respiratory health, eating, or sleeping. Parents describe both positive and negative impacts. They have a balanced view, although scientific literature only emphasizes the negative. The themes of resilience and positive transformation is there. This is also not described in the literature. Parents want more practical guidance about function, not diagnosis, more optimism, and a more fluid communication with the medical team as what is the parental role. So we can see that any way you look at it, the classification we use in neonatology is suboptimal and doesn't correspond to the lived experience of parents. We are more pessimistic and sometimes missing the point.